could fill out the program evaluation, we would really appreciate that. And we will need that from you, especially if you're going to get continuing medical education units. Just a reminder, today's presentation is going to be recorded and it'll be available after the fact for asynchronous viewing with CME. If you have any colleagues who weren't able to be here tonight but would like to see it, they can log in and access it, and they'll actually get CME units for that as well. It'll be on the, it's www.calahec.org. And we can also send that out to all of you because we'll have your email addresses. But we won't be focusing on individuals. It'll be the presentation, but it is happening. The presentation is being offered tonight by funding from the American Recovery and Reinvestment Act through the Office of Statewide Health and Development Planning. So thank you to them. And without further ado, I'm very happy to introduce our speaker, Dr. Gwen Yo. She's the founding director and currently the director emerita and senior ethnogeriatric specialist at the Stanford Geriatric Education Center, which was established in 1987 through the Stanford University School of Medicine. Under her leadership, the multidisciplinary, multi-ethnic Stanford Geriatric Education Center core faculty helps develop the field of ethnogeriatrics. And Dr. Yo has also served as a consultant and presenter for 10 other geriatric education centers across the country. Her work is focused on the development of educational resources and curricula for training in ethnogeriatrics, and she's published over 50 papers and book chapters in this emerging field. She's also the section editor for Ethnogeriatrics and Special Populations for the Journal of the American Geriatric Society, and she's past chair of the Ethnogeriatrics Committee of the American Geriatrics. So, thank you so much for being here.
Thank you, Melanie. That's more than you wanted to know. Thank you all for coming. I'm glad to see that there's interest in the topic of ethnogeriatrics, the topic that our Geriatric Education Center has been focusing on since 1987. And I have to say that we've been funded by the Bureau of Health Professions ever since, and we're very thankful for that funding. So. I want to ask a little bit about you guys. How many of you are clinicians? How many of you are in primary care? A lot, okay. And so I assume that most of you see a lot of older patients. Yeah, okay. And how many, I assume that, I may be wrong, but I'm making the assumption that you probably see a lot of Latinos. Are there other ethnic backgrounds that you see in terms of your older folks that you work with? What other
Latino, black, and poor.
Poor? Yeah.
Asian.
What Asian?
Chinese, Vietnamese,
Uh-huh.
Middle Eastern.
Middle Eastern? Oh, really? Oh, that's good. So it's a pretty heterogeneous population that you're working with. So I want to leave some time for discussion afterwards, but if there's something that actually occurs to you as we're going through and you really want to talk about it, let's stop and ask the question. So these are the questions that I hope that we can try to answer tonight. Why is ethnogeriatrics important? And what tools do clinicians need to care for culturally diverse elders effectively? And how can clinics and other healthcare organizations reduce barriers for ethnically diverse elders? And we'll go through it pretty fast and just sort of hit the high points, and then I'll give you some more resources that if you want to follow up. So just to begin with, can't forward that. So we hear a lot about the geriatric imperative. That is, come in, there are some seats over here. If you want to eat? There's some places over here. You okay? Okay. We hear things like the aging of the baby boomers and what it's going to do for Medicare and so forth. The truth is, we don't hear so much about the fact that there is increasing ethnic and cultural diversity within this, the bulge of that's creeping up our population pyramid, this big bulge of Asian folks. To the extent that by mid-century, 1 in 4 of older adults will be, or 40% are projected to be from one of the categories of ethnic minority. And then within those categories, there's tremendous heterogeneity and diversity within those populations. So when you think about the 1 in 5 Americans that are going to be 65 and older, think rainbow, think multicultural, think, because almost half will be from some population other than non-Hispanic white. So to give you a little visual image of that, these are the population categories that the census tracks: African American and Asian, Hispanic, and American Indian. So looking at it more specifically, we see these are the projections that the Latino will be almost 20% of all older adults in the U.S. by 2050. The African American will grow to about 11%. The population of that are categorized as Asian Pacific Islander will be about 9%. And American Indian will still be around 1%, but they're all growing faster than the non-Hispanic white population is growing. So there's a, those are official sort of estimates, but what's most important is that within each of those populations, there is tremendous diversity. So that just doesn't begin to capture the real diversity that clinicians will actually experience. For example, we're talking about some of you see Asian, but there are Asian elders are from over 30 different countries, and so when you say Asian, it certainly doesn't represent the total diversity, and that's true of all of the categories. Even Hispanic Latino, we think of as more homogeneous, but in reality, it's very heterogeneous. Are any of you seeing people from the indigenous populations? Are you? Mixtec and so forth among the Latino? The non-Spanish speaking, non-English speaking folks. I don't know whether there are many older people in that population yet, but I bet there will be, and so forth. So I think increasingly we'll see more and more diversity with all of them. I wanted to mention that one of your handouts is a chart of the California population from 2010 and the elders from the different populations. And you'll note that already we have 17% of all of elders are Latino, and 13%, over 13%, are from one of the Asian categories. So one particular population that I wanted to mention that's particularly vulnerable is those who we call followers of children, older adults who immigrate after retirement or after widowhood or after they get sick. People are 65 and older, and they come usually with being very dependent on their children because of many a time they don't speak English or don't speak it well, and they frequently don't have an independent income. They're not familiar with the transportation system, and so they are particularly vulnerable and have specific kinds of needs. So we have all this diversity. So what are the consequences for the clinicians? Let's see, where did I go wrong?
The pointer's not working either.
No, you have to step back and
Okay.
access privacy.
So we celebrate diversity knowing that it actually makes our world richer and more interesting, but we also have to appreciate that it makes our world a lot more complex and recognize the need for what we're going to call cultural competence. It's actually, it's the term, we could use some other terms that would be synonymous: cultural proficiency, some other sensitivity, but that's a little bit less specific. So there are two types of cultural competence basically, and one is for the clinicians themselves, the providers. What is it that a clinician makes a clinician competent culturally? And then the other part is the organization itself. And so we're looking first for the clinicians part, and we're going to look at it from the framework of the attitudes, knowledge, and skills. So there's been a great deal of discussion about disparities, and there was a famous IOM report that came out in 2003, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, in which they conclude that racial and ethnic minorities tend to receive a lower quality of healthcare than non-minorities, even when access factors such as patients' insurance status and income are controlled. So that was that was a very eye-opening report, and it showed conclusively that there were disparities, and then since then we've been trying to deal with how do we deal with, how do we reduce those kinds of disparities. In terms of attitudes, I wanted to share a study that has become classic, actually, from the New England Journal in 1999. And in this study, the authors developed 4 scenarios, and they made videotapes of 4 older individuals, and the only thing that they changed between those scenarios was exactly the same diagnoses and clinical characteristics. And the only thing that they claimed that they changed was the race and sex of the person. And they showed them to 720 primary care providers, docs actually, in this case, physicians. And then they asked them whether or not they would refer the person for cardiac catheterization. And you can see the results. And so what they concluded was the finding that race and sex of the patient influence the recommendations of the physicians independently of other factors may suggest bias on the part of physicians. Bias may represent overt prejudice on the part of physicians, or more likely, could be the result of subconscious perceptions rather than deliberate actions or thoughts. Subconscious bias occurs when a patient's membership in a target group automatically activates a cultural stereotype in the physician's memory, regardless of the level of prejudice the physician has. So this idea of unconscious bias has gotten a lot of attention in the last few years, and there have been some attempts to try to measure it, but as you can imagine, it's very, very difficult to actually measure.
On the other hand, it's kind of like karma, because cardiac catheterization isn't really proved to help that much evidence-based-wise.
So why would you recognize anybody? Why would you refer anybody there?
Yeah.
But actually, yeah. But I mean, the fact that there were certain clear differences in the rate that they would. So you're saying that maybe they were discriminating against the white males and black males.
Well, you can look at it that way now, but I doubt that's it. I'm just saying this could be karma.
So this and other studies sort of have given substantial evidence that attitudes certainly do make a difference. A part of the whole cultural competence attitude issue relates to cultural humility, and that's recently given a lot of attention, and the importance of cultural humility in the whole skill set of cultural competence. So it's basically, this is what the authors who came up with this concept, how they defined it. Incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with the communities on behalf of the individuals in defined population. Well, that's pretty complicated, but basically it means that clinicians need to incorporate the habit of constant self-reflection, and that's one of the things that's recommended to deal with the unconscious bias. It also means that clinicians can't be the experts in everything. You know, we tend to think we studied a lot, we're the experts, but there's no way we can know everything about all cultures, right? Or all of the heterogeneity within those cultures. So we have to actually become the students and let the older patients be our teachers about what the appropriate behavior is in many cases. So, and I just wanted to put that out in terms of attitudes and how we might kind of begin thinking about the attitudes. So let's go on to knowledge and skill. So what are the things that we need to know? What are the knowledge base in terms of cultural competence? Well, and on the chart that I included in your handout, there is quite a bit of information about the characteristics of those demographic populations. And for example, half of Mexican American elders in California have less than 9 years of education. And so that would make a big difference in terms of what your expectations of a patient are. Actually, in addition to that, I should tell you that there was a study in Sacramento of over 1,700 elders from Latino backgrounds, the Sacramento area Latino study of aging. And it was a representative sample, census tract-based sample. And they found that 58% of their subjects had primary language of Spanish. 22% had 0 years of schooling. So, I mean, this means never have gone to school. So, if you know that, think about how you would adapt your practice. It certainly means that there's a high risk for low health literacy, not understanding what you might be telling a person or advising them to do, or explaining medication, and so forth. It also means that even if you give the consent form or health education materials in Spanish to a Latino elder, they might not be able to read it. So it's an important issue to be aware of. So then another issue that's important in terms of knowledge is English proficiency. So we find that according to census data, around 60% of Chinese elders and Korean American elders and 80% of Southeast Asian elders, Vietnamese, Cambodian, Thai, Hmong, and so forth, 40% of Mexican elders speak little or no English. So it's extremely important then to think about the need for interpreters at every level, at every interaction, and we'll talk more about that. So it's crucial for a good ethnogeriatric care to include interpreters. there are a lot of, as I mentioned, other kind of characteristics you might want to look at in terms of the chart later. Another issue in terms of what we need to know is knowing something about the background, that historical background that population may have experienced. And we call that cohort analysis. For example, knowing that Latino elders who grew up in the U.S. may have spent their childhood in the back of cars and trucks in the fields as their parents migrated from place to place as they grew up in the 30s and the 40s. Never having had a chance to really have an education or a settled home. African Americans who grew up in the segregated South, where they were not allowed to receive high quality health care and education, or American Indian elders who may have been removed from their homes as children and put into boarding schools too far away to see their parents very often. Japanese American elders who were interned in concentration camps. And all these kinds of things, all these actually have a great influence on the trust that people have in the healthcare system and how they respond to providers. And so it's important to be able to incorporate those quickly into a family health history, just knowing how they may, what experiences they may have had. You can ask, is this something that happened to you, or tell me about your experience with the boarding school with the American Indian. We can talk more about that. I wanted to tell you that we do have a resource on the cohort analysis that's available at our website. It's a set of descriptions of the background of 8 populations of elders in the United States. So another set of knowledge-based issues that comes is knowledge of the health-related cultural values and practices. So many of you probably know about many of the non-Western traditions, such as the balance theories, the Chinese, the yin-yang, and that's also found in Japanese and Korean and some of the other Asian populations. Traditional treatments such as herbal medicines that might interact with prescriptions, health-related practices such as coining and cupping that is thought to reduce wind illness. I don't know whether you've ever seen result of cupping. Do you see that? Anybody see that?
I've seen it in a while, but I've seen it in the past. Yeah.
Have you? You've seen them? You've seen it? And also coining, which would give you stripes, lines on the back or on the chest, where the coins are used to reduce, to allow the wind or toxins to escape the bodies. And so it's important to know that these are not elder abuse if you see those.
That's what happened.
Huh?
It was in a younger person,
Yeah.
but it was assumed there was abuse going on. And
Right.
the whole statement focused on the husband.
Poor parent that got charged with abuse, that's right. And that whole coining and cupping is really widespread in terms of health practices. But, you know, again, you wouldn't know it unless you asked. So, moving on to skills. One of the important skills in ethnogeriatric care is knowing how to show elders culturally appropriate respect. So I want to be sure that you guys go ahead and eat if you get your food, because, you know. We will. Yeah. Okay. Thanks. So how would you know what this culturally appropriate respect would be. And it's really important because in many cultures, or I'd say most other cultures other than American, elders are held in much higher respect. So people, both the elders themselves and family members would expect that they be shown high respect. But how do you know what it is? And so would you shake hands? Would you bow? Would you look at someone directly in the eye? All those vary with different cultures. So we need to. Well, let me ask you: how would you find out what's appropriate with somebody in a culture that you're not familiar with? Mm-hmm.
You might ask them.
That's one way. People say, "How do I teach me how? Teach me how to show respect from your."
If you bow when they bow back, it's probably appropriate.
I don't know. Let's see. Let me test that out. Okay, if you bowed,
You can do a slight bow.
slight bow.
Right.
Well, then I'd probably bow too.
Right.
But I don't necessarily mean that's something I would be.
Yeah, you do it subtly, but
Yeah, well, it
Yeah.
certainly is a mark of respect in a lot of cultures, right? You could also have a cultural guide or a cultural consultant that you could ask. You know, where would you find one? How would you find somebody that could actually teach you those things?
around here.
Google.
I've actually seen the question given in their first, when they walk up in a community health clinic. It's actually in their survey what is appropriate for your family, and it has had the check boxes. I've seen that in certain community health clinics in the Central
You
Valley.
mean they give it out as a written?
And they give it out as a written, as
Yeah.
part of the intake form. And so I've seen it that way, and so that the doctors or nurse practitioners are prepared.
That would be interesting, yeah. Have any of the rest of you seen that?
No.
Clinics?
And I've only seen it in a couple of rural clinics in the Central Valley, but I've seen it, so.
That would certainly, that would be, but again, if you don't speak
If you don't
English,
express it.
if you don't read English, anyway, yeah, but it would, if you use an interpreter, certainly that would be good.
Not all the time, but if you have, people can tell when you're sincere or not. There's a certain energy, don't you think?
Well, I hear that as an excuse a lot.
Yeah.
Yeah, but, well, you know, there's no way we can know everything about every culture.
Right.
So you just really, be really nice to everybody. You know, but I mean, I still think that it would be a great skill to know how to approach them in a culturally appropriate way and how to show that respect. Like, I have a colleague at Stanford that I've had this discussion with, and he is a great, culturally competent physician. And we've had this discussion about whether or not to automatically shake hands with everybody. And he would shake hands even with someone from the Middle East who's in a different gender. And I would say, you know, that's probably not a good idea, you know, that to put somebody in that position to do something that would be against their rights. So there, you know, certainly there are two ways of looking at it, but I think that it would be a wonderful skill to have to be able to show respect in a culturally appropriate way. And in terms of Latino, you know, many, but certainly not all older Latinos may have the value of personalismo, so that when somebody comes in for their first time, just launching into, well, what brings you here today, or what can I do for you today, would seem abrupt, and that if you'd be much more seen as respectful to establish a personal relationship more.
Or even like calling them in Spanish, it's tú for young people, and it's usted for elderly people.
Right.
So when you say tú to someone older and you're younger, it's kind of like,
Yes,
it's not showing respect, it's more like usted and, you know.
So especially, yeah, and the gender, I mean, the age relationships are really important in terms of, you know, showing, using the right terminology. Good. And again, these are things that you can learn by talking to the patients and also by the cultural guides that you develop. And the cultural guides, I should say, priests are a really important source. Someone from the religious community, clan leaders, interpreters can help with those issues. So, showing respect usually means for an elder acknowledging the elder first. If they come with, as many elders do, with a member of the younger generation of their family, rather than, even though the younger person might be the one that speaks English, the temptation is to greet that person first. In reality, greeting the elder first would be the expected and a sign of respect. Using the formal terms of address are also one way to show respect, and especially for populations that have been disrespected, especially African American elders who may have grown up in the South and have always been called by their first name or by boy or something like that. It's important to show, to use the terms Mr. and Mrs. But I was told by somebody from a Cambodian background that didn't necessarily hold true for Cambodians, but I haven't checked that out with more than someone else. But in most cases, using the formal terms until you're given some. And I want to ask you a question. When I tried to bring that up with my own providers, when I'm sitting in the waiting room and the medical assistant comes in and calls me or somebody else Ruth, or she might call Gwen, white-haired, 70-plus-year-old Gwen, and I go cringe, and especially if it's someone else. But I've been told that they have to do that because of HIPAA.
Yeah.
Is that really true that you can't use your last name?
I don't know if it's true, but it's become part of the culture now that everyone, you can't even write a name down anywhere.
Unless there's like 6 Juans in the room, then you have to say the last name. Because we have it sometimes where we're giving shots and there's like a lot of Marias or a lot of Juans or
It's really gotten
a lot of Johns. So
the patient itself will say their last name.
Yeah.
Us pronounce it and they'll say it.
Yeah.
Oh, okay.
Or
So
ask
if
which
you're not in the
one.
waiting room, can you call them
Mrs.
Mrs. Martinez or something? But if just in the waiting room, do you have to call everybody by their first name?
Where it's public, where other people can hear.
Yeah.
That's a real shame.
Yeah, I don't know. Someone's gonna make a stink eventually.
Yeah.
It's complicated.
Nonverbal communication is really important, and it certainly varies by different cultural populations in terms of, we were just talking, Tom and I were just talking about experience with American Indian patients or elders, how the pace of conversation is culturally very, very slow, and it's so easy to get impatient when, when the time pressure is on, you have to take 10 minutes, and but it would be a great way of showing respect is to take the silences as important and value those. physical distance, eye contact, expression, gestures, whether or not to touch the patient. Gestures can really get us into trouble and very easily misinterpreted. So, if I were asking somebody to come here, I might say, Mrs. Martinez, would you come here, please? And if that person happened to be from the Philippines, she might feel very insulted. You know, because is anybody from the Philippines here?
Yeah, you don't point.
This is the way you call animals, and that's true in other cultures as well. So the more polite way is to use your hand this way. Would you come here, please? And so gestures can really be misinterpreted. There's also in the Middle East, it's important for you not to show the bottom of your foot because that's a real insult. And there was a story about Bill Richardson, who was sent to negotiate with Saddam Hussein when they were trying to get some people he was holding hostage, get them released. And Bill Richardson sat with his legs crossed and showed the bottom of his foot, and the whole negotiations almost fell apart. And so, but the interpreter had to say, no, he didn't really mean it. He didn't really mean it. But you know, so it's some of those things that are so automatic with us, the gestures, we can become much difficult with people who have different interpretations of it. So just being aware. Nodding is sometimes, it has different meaning. So in many cultures, you nod to show somebody respect. Your talking doesn't necessarily mean I agree. Sure. Touch is another place where a lot of us assume that all older people love to be hugged or touched. But it turns out that that's not always true. I remember one of our first conferences we did with some folks from different senior centers, ethnic-specific senior centers, and the lady who was representing the Chinese Senior Center said, a lot of our elders don't want to be touched. And there was this audible, the very idea that people don't want to be touched, but that's it's not considered appropriate, or it's not expected to have the kind of touch that we frequently do. Other populations certainly want to be touched, and hugs are very appropriate. So again, this is a situation where you need a cultural guide. Another skill is eliciting explanatory models. And this was a tool that was found to be important in cultural care. That was introduced by Arthur Kleinman and his colleagues from from Harvard. And so the whole purpose is to understand the patient-client's perception of what caused the condition that is being addressed, so that it can be incorporated into the management plan. And so these are some of the questions that he suggested, talking to the patient about what do they think caused the problem, what did they call it, when did it start, what does it do, what did you fear, what kind of treatment do you think you should receive? And this is a hard question for a lot of clinicians to ask, because they think it shows that they're not competent. But if the person is expecting certain kind of treatment, like in Vietnamese, because a lot of elders lived in Vietnam during the French occupation, and the French tend to get shocks for everything. They expect shocks. And so if they didn't get a shot, they would think that maybe it was not effective care. So knowing what kind of expectations is sometimes really important. You might say something like, I have some ideas about your condition, but I'd like to hear your perception first to see what you, how you perceive your situation. And ask some of these questions. I wanted to give you an example of one situation where we looked at the explanatory model. I had a student who spoke Khmer, a medical student at Stanford, and she interviewed 76 elders from Cambodia that lived in San Jose. She asked them what was their chief complaint, what was the thing that bothered them most, and what they identified most often was headaches, but it wasn't just any headache. It was headache so bad that it caused dizziness. So it was a massive headache and dizziness combination. And then she asked them, well, what did they think caused it? And the most common explanatory model that was cited was the Pui Chit Tran, which I probably am not saying that right.
I'm a storyteller, and I make things up until people finally don't believe me. And my wife is Vietnamese, and I was telling her about what is the female, the anger, the menstrues, what do you call it? PMS.
Oh,
I was telling her about PMS. She thought I was making it up. She thought I was telling her a story. And that there's no such thing as PMS. Don't pull my leg. And then wait till we get to the library or the bookstore. And she was just amazed that there was such a thing.
right.
In Vietnam, they don't have PMS.
They're different, there certainly are different labels that people give to similar symptoms. There are different constructions of illness that are believed in many different cultures. This Pui Chit Kitran was actually, it's hard to translate accurately, but it means something like sadness from thinking too much. So that was the most common explanation. So what do you think Cambodian elders might have been thinking about that would cause their, or in their view, cause their headaches?
What did they do this in their country?
Immigration trauma, and then, I'm sorry?
Money.
Money.
In a different country.
PTSD. Well, actually, yeah,
Respect for Americanized children?
that's a really big one, lack of respect. That's true. That's been found a lot with Vietnamese elders, is the fact that the second and third generation are too Americanized, and they're not holding the Vietnamese values. But also, this is the cohort that experienced the Pol Pot killings and from the Viet Cong, and so they all lost members of their family. Some of them, were in refugee camps for 5 years and had to actually go through rivers to get out and things like that. But you can see they also believed in things that the typical American mainstream person might believe in, that's causing headaches, physical stress, aging, the imbalance of the elements, a hot element, again, this with hot, cold balance, it believes, karma, that they've done something wrong, their ancestors did something wrong, wind illness, and so forth. So there, unless you ask, you don't you don't really know what people think caused some of their situations. And so you would if you said take 2 aspirin and call me in the morning, it wouldn't actually get at the kinds of issues that they think were important. So I thought maybe we'd look at some of the main geriatric chronic diseases and look at some of the disparities and management issues that come up in terms of cross-cultural care. Diabetes is something that most of us realize that there's a tremendously high risk of diabetes by elders from different other ethnic groups. Compared to the non-Hispanic white population, Mexican American, Indian, African American elders are 2 to 3 times more likely to have diabetes. And so that's one of the conditions where promotores can be very helpful. Do any of you have promotores that work in your clinic? Promotores are actually people that are recruited from the background of the patient population, and they don't necessarily have to be professional or well-trained. They can be lay people, but then they're actually make the connection and the liaison between the healthcare staff and the patient population. They've been very effective in after being trained to do health education and to have people with diabetes continue to on their diets or check their blood glucose, things like that. So they can be extremely helpful in that situation. Now, in the Health Reform Act, I think there's more emphasis on patient navigators. Hopefully we'll all be able to try to utilize, and that's very similar to promotores or educators. So they're basically lay people that can be there. And actually they can also be very effective in teaching the healthcare staff something about the population as well. They can be your cultural guides. Another issue that comes up with diabetes is the use of medications from Mexico or other countries where they visit often. So if you have elders who or their family members make frequent trips to Mexico or China or the Philippines, we need to explore the possibility that they're taking either herbal or prescription remedies from there. In terms of herbal medications, the most common finding is that a lot of elders who are immigrant elders, people who are first generation, are taking herbal medications from their countries of origin, but almost always they will not tell the Western doctor or the Western healthcare provider unless they're asked. So sometimes you're going to get into situations where they may be taking an herbal medication that has the same effect as the Western medication that you're prescribing. So unless you ask, you wouldn't know that.
I find a lot of interesting stuff in ears.
Ears? What about ears?
Like cotton and certain swabs and oils and turmeric and a lot of different things.
To
It's a
deal
whole
with
remedy.
earache?
Yeah.
Well, if the blood flow is supposed to be closer to the brain too, so not just earache, but just get a theory of the blood flow, if it absorbs in your ear, it's that much closer to.
So the belief is that you can give medication through the ear. That's run into that. So, cancer has a much higher risk among African American men, especially, but women as well. Not so in terms of Asian Pacific Islanders or American Indian or Hispanic. So when you hear, and unfortunately this is very common, you hear something about disparities and then they'll say things like minorities have a much higher rate But you have to be really careful about that because frequently there's a different risk depending on what minority you're talking about. So it's important to be conscious of that. One issue that comes up in cancer care for elders from different backgrounds is, especially among Asian and Middle Eastern families, is a request from the children not to tell the elder of the diagnosis. And this, of course, can be a real difficult dilemma for the clinician because of the assumption in the American system that an individual has the right to make their own decisions and they should be informed. So some solutions that have been suggested by some geriatric ethicists is to include asking the elder how much they want to know about their situation and who they would like to make the decisions without being specific. And of course, best of all would be if you had a continuing relationship with an elder that you could ask before there was a crisis. And so in general, if you have a condition, who do you want me to talk to about that? Do you want me to talk to your eldest son? Do you want me to talk to you? Or who? Did you indicate that you've had that situation?
Well, yeah, I worked in hospice, and also there was a study that was out that was only 7% of people that come to the hospital have an advanced directive. So there's a lot of work that needs to be done with that kind of healthcare choices before they get to the emergency room. Maybe.
For sure.
Yeah.
Yeah, but they want to talk about it.
And
Right.
and advanced directives and hospice are not models that a lot of people from other countries are familiar with. It's really a very Anglo model, and so there's much much lower utilization rate among other populations other than non-Hispanic white. Oh, depression is another issue that comes up a lot, and you can see this was a recent study from the Institute of Medicine when they were looking at 3 different nationwide studies, surveys about mental health issues. This was in a report on mental health in Asia, and they found that well, first let me tell you that the only Asian language that they administered the survey in was Chinese. So it probably doesn't represent, it didn't catch the high PTSD and depression rate of Southeast Asians, which has been confirmed in a lot of studies. But you can see from this that there's a much higher rate of elders with depression, with the 3 type of depressive disorders among the Latino population. And again, this has been confirmed by others from many studies, is especially among Mexican American women have a much higher rate of depression.
When I was in neonatal care, recovery of a kid that's born premature, the best recovery evidence was for the Hispanic child. They were really taken care of well afterwards. But the whole family blamed the mother for everything, and she got the burden for everything. And so, she gets the credit for the success, but also the blame at the same time. It was very difficult.
There have been other kinds of suggestions of causes, and like because of the loss of the role of older Latino women when after the children leave home and so forth. So there are a number of suggestions. The cause is sort of elusive. But primary care providers are usually the ones who see the depressive elder first and maybe the one that's managing it. So I wanted to look, there have been some work on cultural issues and assessment of depression, and certainly we know that somatization is much more common in Asian populations where they don't necessarily talk about the emotional part of depression, but talk about it in terms of stomach aches or headaches. So that should be checked out. Depression should be checked out if people present with a somatic, generalized somatic situation. I also wanted to mention that the geriatric depression scale is available online in 36 different languages, and some of those have actually been validated, and others haven't, but they are. It's a tool that has about 15 items, but it's a yes/no format. It's very easy for people to respond to. But you can download those, and they're actually printed in the languages and the alphabet of the population, the total population. There have been some studies on the mental health barriers to the treatment of people with mental health, and from different cultures. And stigma is really a big issue in many cultures. The idea that if someone has a mental health condition, that it reflects on the whole family. So it's not just the person who has the stigma, but the granddaughter might not be able to get married, or the son may not have a good job, or so forth, because of it. So these are some of the other barriers that come up. Treatment preferences have been found to be different for different populations. In one study that was published in 2012, they found that African American elders were more likely to seek spiritual advice. Latinos are more likely to prefer being given pills, but they don't want group counseling. And the Asian Americans, which were all lumped together as Asian in this study, but they didn't like the group counseling either. And that would be consistent with kinds of stigma that are found in those populations. I know that we're probably running over. Do you want me to go on? Or
15 minutes.
15, yeah. Okay. So, and if anybody has to leave, feel free. I just want to say a word or two about dementia, because that certainly is the epitome of a geriatric condition. And this is one of the studies that has been quoted most often in terms of the different risk of dementia in different populations. It was done in Manhattan, certain census tracts in Manhattan. And you can see at every age that dementia was higher for Hispanics and African Americans. But I should tell you, there are two things to know about this study. And one is that the Hispanics in this study were all Caribbean. They were all Puerto Rican, but mostly Dominican. And there were no Mexican Americans in this study. So it shouldn't be considered Hispanic. And sometimes they talk about it as Caribbean Hispanic, which I think is much more accurate. And the other thing to know about this study is that when they actually controlled for education and age between the populations that they studied, all the differences disappeared. So there were no differences between the populations. So it tells us that education is a huge factor in the differential risk for different the other thing that I wanted to contrast that with is the salsa study in Sacramento. And in this case, these were primarily Mexican Americans. And in that, they found that their dementia prevalence was 4.8%, which is in the same range as most of the studies that were non-Hispanic white dementia of older adults. And certainly it was about 1/3 of the rate that they found in the North Manhattan study of the Caribbean Hispanics. So we have to be really careful when we're talking about rates of dementia in Hispanic populations who we're talking about. We also should realize the increased risk of dementia with folks with diabetes, and that's another reason to be really important to treat the diabetes very carefully and stroke. But this was a population that's, you know, low education levels, very low education levels, and yet they still didn't have the high risk for dementia that we might expect. There's a resource that cultural influences of late presentation. Now, one of the consistent findings about dementia is that in people from, quote, minority populations, unquote, tend to present much later for assessment. And a lot of that seems to be related to the fact that the belief that dementia is a normal part of aging. So, and everybody just gets demented when they get old, you know. And there was the finding that dementia is believed to have a spiritual or other causes. Somebody put a hex on me or him, or they were worrying too much about something, or there were many I did something wrong, God is punishing me, that kind of thing. And there's tremendous shame and stigma that also interferes with the presentation for assessment and treatment. Belief that nothing can be done about it, or the lack of trust. Anyway, there are a couple of assessment instruments that have been developed especially for cross-cultural screening. The CASI has been validated in many different languages and translated, including Spanish. And the RUDIS is actually an Australian assessment, which they say is it only has 3 items, but the authors say that it's at least as accurate as the mental status exam, and does not appear to be influenced by language, education, or gender. What it is actually things like if you're going to the store and you want to buy something, it's very common sense stuff. Something, but so it is an interesting one. I haven't seen it used here very much, but it's an interesting idea. There's a resource that we developed that's now in their 2nd edition that is very specific to different populations on ethnicity and the dementias, and for assessment and working with families from 12 different populations. I want to mention something about management of dementia. I want to let you know that there is disparities have been found in the major treatment available for Alzheimer's, which is cholinesterase inhibitors. The African Americans and Latino elders are much less likely to receive the cholinesterase inhibitors than non-Hispanic whites. And I'm not sure what that's about, but either it should be the late presentation related to it, or other factors. But the most important thing that primary care providers can do to help families is to work with the caregivers and support the caregivers. So this was a study that we did of the first 5,000 participants in the California Alzheimer's disease diagnostic and treatment centers, and we found some differences in who was most likely to be the caregivers. And Hispanic and African American was much more likely to be a daughter. Son was more common in Asian populations, and African Americans were more commonly had other relatives as caregivers. So the most important thing a primary care provider can do in cases of dementia is to support the family caregivers. And the worst thing they can do is to tell the caregiver there's nothing else we can do. Not only can the cholinesterase inhibitors be tried, but and followed up, but referral to community supports, ethnic specific or ethnic appropriate community support systems like the Alzheimer's Association has lots of ethnic specific resources. Certainly adult health centers and so forth are extremely important. But if we're talking about late stage dementia, you know, providers frequently think, will suggest that the elder be put in a nursing home to relieve the burden of the caregiver. And it turns out that that's not an effective strategy for many elders from different ethnic populations because of the strong belief in the importance of family support and filial piety that they would much rather do everything possible to keep the elder at home and would feel terribly guilty if they actually had the elder in a nursing home in some cases. I just wanted to mention the term burden that's frequently used with caregivers. It's not a word that probably should be used with a lot of elders from different caregivers from different ethnic populations. They don't relate to the burden piece of it. It's more, this is our family, this is what we do. This is an example, this picture, a resource that was developed by my colleague, Dr. Dolores Gallagher Thompson, and she has worked with caregivers from many different populations, and she's developed some resources based on cognitive behavioral therapy approaches that have been found to be very successful. This is a photo novella that she's developed both in Spanish and English, and now they're doing a video novella that's based on it for the use with Spanish-speaking caregivers. We don't really have time to talk about it, but I do want to just mention that end-of-life issues are extremely varied by different ethnic populations, and the beliefs vary tremendously and culturally from one population to another. If we have time, we could talk more about that. I just want to also mention that the other part of cultural competence is organizational cultural competence. And so it's usually conceptualized as a continuum from an organization that's very destructive toward cultures, toward being very proficient. And you might think about, where does your organization fit? With blindness sort of being in the middle, with like not recognizing any particular differences in terms of needs, and we treat everybody the same kind of issue. So there are certain motivations that really help to move an organization of that continuum. The Joint Commission has developed some very specific standards on cultural competency, and the class standards, which we'll talk about, and the evidence that medical errors are much more common when in less culturally competent organizations. The class standards I have included in your handout. They've been recently revised. Just a couple of weeks ago that they came out with a revision. They originally was developed by the Office of Minority Health and a number of other agencies in the federal government after long periods of development to help organizations say what is it they should do to become culturally and linguistically appropriate. And so you can, if you have time to look at it later, you can, but one of, there's an emphasis on the linguistic issues, on language access, but they also talk about hiring staff at all levels to reflect the patient population, training on cultural competence, maintaining a database that includes patient ethnic and racial identification and language preferences. But the 4 on language access are considered mandatory or they're legal requirements because they're based on the Title VI the Title VI of the Act, the Civil Rights Act. It says that no person in the United States shall, on grounds of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal assistance. So, and courts have made the judgment that language access is considered discrimination. And so, legally, you can be prosecuted if you get, an organization can be prosecuted if it doesn't provide interpreters, for example.
Yeah, so what they do is they get the blue phone system, then no one uses it.
That's another problem, isn't it?
Right.
So is that the organization's problem, or is that the...
Well, it's not easy. You don't have time sometimes, you know?
We work in the same clinic, and I didn't know we had it, so I'm going to call that organization's problem, but I didn't know we even had it.
No, we don't have it. I'm talking from
okay.
other places. We don't really.
You don't have it?
No, but.
But of course, the
99%
VA actually is a little bit different because the assumption is somebody goes through service.
We got the tools, but
You think
people
we
don't
don't have
use
to go
it.
with every single federal statute laid out there?
Yeah.
Well, for instance, most of our doctors, they don't know who dumb our caregivers are.
But I think, you know,
They don't.
I had this great interaction with a coworker. He's from San Francisco, and he was at Kaiser, and I was asking about the language line, and he was saying that every unit at Trump, they have the 2-phone system.
Yeah.
And he said by us using that system and we're going to model how it's not complicated, how it's not difficult, because people are grabbing housekeepers or people are
Right,
grabbing
it's
other
easy to
people.
grab a housekeeper.
And he said that's legally, you can
be
be prosecuted. You can only use those people if you first documented that you have tried the language line or whatever. So it inspired me to go to the floor, get the phones, and it also builds intimacy with the client when you're, talking. So I think there are easier systems out there, and I think it's just like sometimes health professionals go, oh, I don't want to use the Hoyer lift, because it's so organized. But I think the language line, and when you're definitely with culturally humility, we have to use the language lines that our organizations have because of Joint Commission and be a model of that tool.
Oh, I
But
think
also,
so.
we have a very much geriatric population. A lot of hearing impairment, they can't use telephone.
Yeah.
I mean, they just cannot hear, and they have hearing aids, and we have microphones, and it just rings, it reverberates, when you get close to the
Right.
microphone, so.
But if a Hispanic person comes in with a family member, and usually, if the family member can hear, or I think we just need to make an attempt. I mean, a lot of people have hearing difficulties.
Yeah.
And they may not be Hispanic either, so I think that we should attempt.
Yeah, we have to change the culture, but, all these laws don't make a difference. In the ACA, if you're 64 years old, you get a free cognitive screen as part of your wellness visit starting January 2011. I have yet to be one person who's ever had a cognitive screen over 64 by their provider.
Right. Well,
And that's law.
It's the nurses. I mean, I had this experience where this family member came up to the doctor, and the doctor was dealing with the acuity, and I had him draw. I just learned about this, so I have a new job, so I was highly motivated. So I had to draw the clock, and now the wife has a baseline clock
Yeah.
to take to her provider. But and then I did another one with this patient, and the provider was like, "What are you doing?"
Yeah,
So I think it's
Yeah.
we that are getting educated need to kind of promote this because, the Great Alzheimer's Association on Ryan Ranch, to put a plug in them, they say that it's 3 years before somebody gets into the system of the diagnosis, 3 years that they actually have dementia or Alzheimer's before they get diagnosed. And there's a lot of things people can do in that 3 years. So just
But
impressed.
getting engaged, I get better results putting stuff on the bulletin board than I do talking to my doctors.
Well, and the other thing is it takes somebody within the organization to be a promoter. So, you know, one person can make a lot of difference if that person really believes in. And let me just show you, not only do we have, you know, is it the law that they, and also you're not supposed to use minors, never use a child, never as an interpreter, or untrained individuals, and even though that's the most common is use of family or
By child, you mean someone under 18, or, because we're talking about elders and their child might be 30, 35.
No, I'm talking about minors. Okay. Children, real children. Yeah, not adults.
Some of our veterans get children.
But just in terms of, there's now some literature on the evidence base for interpreters. And there was a real comprehensive review of the literature in 2007. They found that there was a use of professional or trained interpreters of overall improvement of care, decreased communication errors, increased patient comprehensive, better utilization, improved clinical outcomes, increased satisfaction, and for limited English proficient. And then more recently, they found more specifically studies that it reduces the errors of potential consequence, not an ad hoc or no interpreters, and it, in terms of hospitals, their use of interpreters at admission or discharge, or both, result in shorter lengths of stay and lower readmission rates. So those are going to be really important in the healthcare reform movement. So, I mean, if somebody believes in it, there needs to be an advocate out there to try to change practice. But I know that practice is hard to change, and the whole time element makes it. But they've found, there have been some studies which indicate that it really doesn't, if the organization gets an interpreter, if you have on-site interpreters, if you have a system where you can get the interpreter there at the same time the patient is supposed to be seen, then it doesn't really add that much time. And so where the time is waiting frequently for an interpreter to show up. But I can't believe that people who have hearing aids can't use telephone. There must be some way of making that happen.
There are adaptive devices.
Yeah.
There are
Yeah.
devices,
And you can get them for free.
Yeah, that's right.
But
I
you
can
gotta
tell
get
you
the
probably
phone.
at least 6 to 7 times a day, I someone told me, I couldn't use the phone, I couldn't understand what they were saying to me, I couldn't use the automated thing, press 1 to do that.
Right.
So a lot of it is the hearing, a lot of it is you press 1 to do this, you press 2 to do
That's
that.
right.
Can't
But
do
you
it.
know, if VA has an occupational therapist, they can plug those people into the adaptive equipment. And sometimes it's just about delegating people to see people. And I think we have to be creative to, you know, like in PJ, they have a vision impaired center. And, you know, there's just those resources out there, but people are falling through the cracks. And so, and then the nurses or whoever's end up doing, and the occupational therapist,
Pharmacists.
yeah, the occupational therapist can really help people.
Yeah, you ever heard the story about the kid on the guy on the seashore that washes up all the starfish? And there's thousands of them. And he's throwing them back in, one at a time, right? And it's like, what difference are you gonna make? You know, and the only difference is that one you're taking care of.
Well, and
And
that's,
that one that makes a difference to you. But it's hard to overcome the masses that are falling through the cracks, you know. It only goes so far for that one.
But if you were that one person,
Yes, exactly.
Yeah, I know, but I get burnt out, I get frustrated, it's hard.
burnout is a big issue, that's right. I don't know if, I think we need to end, but I just wanted to make one final point, and that is the American healthcare system is its own culture. And it itself is a barrier to a lot of elders, you know, who are less acculturated. It's a big barrier to most of us, you know, but to those who don't, you know, and you know, it means elder is supposed to be on time, sit quietly, wait for the provider who's not necessarily on time. It means that there's fill out all the forms. It means that they have to come see specialists, every specialist for every different thing. And that every time, it means that somebody has to bring them. And it also means that somebody may have to take off work, and frequently at no pay. So those are huge barriers to us to actually the good care that we want to provide. So this is the Dory Thoughts is a great set of references. It was developed by the Ethnogeriatrics Committee of the American Geriatric Society. I recommend it. It's like, what do you need to know before you open the door to somebody from a population that you're not familiar with? And so it's three small volumes. I recommend it highly. And we have a lot of other resources on our Stanford Geriatric Education Center website as well. So, would you like to any kind of questions you want to talk about? I know that you probably need to go. But thank you very much for coming.
Thank you.
So thank you, Dr. Yo, and thank you all of you for joining us. I hope you enjoyed the presentation and your dinner. Just a reminder to fill out both sides of the participant information form. And if you would, there's also an evaluation on a separate page. You can fill all those out and pass those into us. And we're most grateful.
And will you mail us our certificates or?
Yes.
Okay.
And have a great evening.
Thank you. Great venue.
Yeah, it is.
Yeah, right.